Hi Ravi, can you hear me? You getting the audio? You okay? We're all set? Sure. Yes. Hi Ravi. Yes, I can hear you. Am I audible? Am I audible? Thank you so much, Ravi. It has been an extreme pleasure to be invited on this special platform today by Professor Ravi Kanodia. Thank you very much, Professor Ravi Kanodia, for inviting me on this special platform today. Uh, on behalf of IAPS, uh, to talk to you today on this scientific topic. First of all, I welcome you all on this very auspicious day of Parasita, Parani Bharat, Ramjan, and many festivals. Esophageal replacement in children is a situation where many pediatric surgeons we are called upon to perform. So I'll cover this topic with some subheadings like what are the indications, what are the different procedures available, how do we make a choice between the procedures, what are the outcomes, and in the end, what is the right procedure for a particular patient. There is no ideal substitute for the esophagus. The native esophagus is the best. However, we all will face situations in our practice where it would not be possible to get a functional and anatomical normal esophagus. And in those patients, a replacement will be called for. In pediatric surgical practice, these are the list of indications. Long gap esophageal atresia tops the list in our practice because even today, the long gap or the pure esophageal atresia are managed in many Indian centers by early diversion. Although that is not ideal, the ideal treatment is delayed primary repair. But due to local constraints or lack of facilities, they are diverted and they require later esophageal replacement. Of course, failed primary anastomosis introduced with the fistula, recalcitrant or difficult esophageal strictures, not amenable to other managements, and few rare conditions. It is pertinent to know a bit of anatomy, recapitulate a bit of anatomy of the esophagus, especially its blood supply. If you see the esophagus, upper third, middle third, and lower third has difference in the pattern of blood supply. The upper third, the main blood supply comes from the inferior thyroid artery, which comes from above, below from the neck. And that explains why we can deliberately mobilize the cervical esophagus. Whereas the thoracic esophagus, there is segmental supply from bronchial arteries and aorta. So with the lower third of esophagus, which has a segmental supply coming from ascending branch of left gastric artery, hence mobilizing this esophagus too much would devascularize it. Similarly, it is important to know the curvatures of the esophagus. As you can appreciate, in the upper third, in the neck, it is deviated towards the left. Hence, we prefer doing left-sided cervical esophagostomy. In the middle, thorax, it remains almost in the midline, maybe slightly towards the right. We prefer a right thoracotomy. As it enters the abdomen, it again deviates towards the left. So either we give a left thoracotomy for lower third or upper abdominal incision to get the gastroesophageal area. The two important structures, one should grow with the child, it should be long lasting. There should be a simple technique to do it, should not have much acid reflux, should not cause respiratory or cardiac embarrassment, no cosmetic deformity, and minimum post-operative complications. So these are all ideal criteria for a substitute. Coming on to when should we be doing in a child replacement? Well, our patient will start from the newborn age, but to do an esophageal replacement in the newborn period, I find is a very major undertaking, and I would try to avoid or recommend avoiding it in the neonatal period, though I am aware that some centers have reported good outcome and results even in neonatal esophageal replacement. But in my practice, we do not do neonatal one. When do we do that? Generally 7-8 months is a good time, and beyond at least 5 kilograms. I would prefer 7 to 8 kilogram body weight minimum for a baby to be considered good enough to undergo esophageal replacement. In case of esophageal strictures, the indications are that you have failed all conservative means and repeated dilatations requiring beyond 6 months or 12 months is definitely an indication to replace such an esophagus, because that's not going to be functional. Next important part are the roots of esophagus. We generally replace with some viscous taking out from the abdomen. So to reach the thorax, there are 3 routes. One is retrosternal, nicely available route. The second route is transthoracic transpleural through a thoracotomy. And the third I have shown here is posterior mediastinal, which is a normal anatomical place for the esophagus to lie. We will see the application of the routes, their advantages and disadvantages. Each one has special advantage and disadvantage. Retrosternal route is quite easily created, and especially it is useful where your posterior mediastinum is scarred and it is not available for safe operation. However, it's not a shortest route, and there could be angulation of the graft, especially 2 areas where it enters from abdomen to chest and again from coming out, emerging at the neck. Swallowing problem. So it is very difficult to get back and undertake the procedure. As regards siting of the esophagostomy, well, the first question is the left or right. I think it is a surgeon's preference. You could either way. I have been doing right esophagostomy and have not faced many issues. But as you have seen, that the majority of world literature prefers a left esophagostomy. Wherever you do a low esophagostomy, maintain it well, make it a good caliber so that it doesn't steal nose, functions well in terms of discharge of saliva, and would be available for your future esophageal replacement. and gastrostomy, as I have shown in this baby. Jejunal interposition, and then some more modifications of those, like a fundal tube esophagoplasty, as described by Professor K.L. Rao, a pedicled interposition bowel graft, and tissue engineered graft is something we will be looking for the future. Whether there are experts who can do the whole procedure through laparoscope and if necessary through thoracoscope, as evidenced by their publications already coming up with successful thoracoscopic and laparoscopic gastric pull-ups. For the postgraduates, this is what we meant of a gastric tube, that you can make a tube out of the greater curvature, or you could pull the whole stomach up in the neck, the total gastric pull-up. So we'll see a bit detail about those operations. Here I'm showing another technique where this is an extension of Charlie's lesser curvature elongation technique by Professor Rao, which is called fundal tube esophagoplasty. Instead of giving a horizontal cut, Professor Rao recommends an oblique cut or a curvilinear cut parallel to the greater curvature, so that when you elongate the stomach or the esophagus, you could use the lower part of the gastroesophageal junction and the esophagus up in the neck. Of the bulk by doing a greater curve gastric reduction. Whereas what I have realized that when you remove the esophageal stump in case of pure esophageal atresia, I mean, you could just take a little bit of lesser cuff along with that lesser curvature cuff, and it will serve the same purpose. It is not always necessary to do the reduction. Only if you have a big bulky stomach or if you have difficulty in pulling, then only think of. Otherwise, it is unnecessary. All procedures have their own advantages and disadvantages. Gastric transposition, it's a very simple procedure, good blood supply of the stomach, no issue. Best advantage of it is single anastomosis in the neck. And you avoid a thoracotomy if you go through the transhiatal route. However, in our earlier days, we faced issues with cardiac arrhythmias, respiratory distress because of big bulk of the stomach, dissection behind the membranous trachea, and that could be a major issue in the early post-operative period following gastric transposition. And anybody undertaking this procedure should be prepared beforehand to handle or tackle immediate major post-operative complications. This we have already discussed, that we could create the passage by blunt finger dissection through the hiatus and another finger coming out through the neck. And then our practice is we pass a Hager dilator from the neck, then fix it to a big bore chest tube, pull the chest tube out and pull the fundus of the stomach up in the chest. So this picture essentially shows the preparation for doing a gastric pull-up. All the vessels are divided around the stomach. Only left gastric and the left gastroepiploic artery are the two left, the right gastric and the right gastroepiploic artery are preserved. The left gastric divided, left gastroepiploic divided, short gastrics are divided. Fundus of the stomach is the highest point. The esophagus would be removed and fundus of the stomach would be joined. This is the esophagostomy. As I said, that the route would be posterior intestinal transhiatal, or even in difficult circumstances, if you have a big bulky stomach or posterior intestinal not available for some reason, you could use retrosternal route as well for gastric pull-up. This is where the stomach has come up to transhiatal posterior intestinal route and ready for anastomosis. Balloon dilatation. I have not done pyroplasty in many. We feed them in the post-operative period through a feeding jejunostomy, and we got away in many patients. But whether you do a drainage procedure, and this is required, invariably both the vagi will be divided, so one can anticipate some element of gastric paresis. A 2 to 3 finger breadth posterior mediastinal tunnel is essential. And once you have finished the procedure, fix both the neck anastomosis as well as the pyloric antrum to the diaphragm. There could be several early complications related to the surgery and some late complications, especially swallowing. When we lost few patients due to cardiac arrhythmias, we consulted a cardiologist and reviewed and found that there could be some inappropriate sinus tachycardia or some kind of a cardiac arrhythmia due to our dissection in the posterior mediastinum close to the heart and close to the sternum. And nowadays, we prime the heart with preoperative beta blocker, and our practice is to continue post-operative beta blocker with thorough monitoring. And if the heart rate goes above 160, 180, we definitely do that result. And since 2006, we are doing that. We haven't had a mortality from cardiac arrhythmia. This shows two major complications. One can see acute gastric dilatation and a pneumothorax, collapsed lung and acute gastric dilatation. So always empty the stomach through a nasogastric tube post-operative period. And if you get a pneumothorax, drain it with a intercostal tube drainage, and that's it. We recommend elective ventilation, although I am aware that some surgeons do away without it. But our recommendation is ICU, elective ventilation, strict monitoring, nasogastric decompression, pain relief, and early jejunostomy feeding is absolutely important. We do a quick jejunostomy with a simple feeding tube and have had good results since then. The contrast study generally looks like that. Some bulk of the stomach in the chest. They all empty by gravity. Coming to gastric tube. The standard gastric tube which has been described is from the greater curvature side of the stomach, placed on the left gastroepithelial artery. Tube size of 22 to 28 French, starting from 2.5 centimeter of the pylorus, and that's the standard technique described. And then the tube can be taken in the neck, generally through a retrosternal route, or some people can do posterior mediastinal. The main problem I see in this gastric tube is a long suture line. You may use stapler, you may use hand suture, but this is a long suture line. So if it leaks, there is a risk of mediastinitis, which is a dreaded complication. What we have adapted is when we do gastric tube, we make a fistula, neck fistula, and do the anastomosis in the second stage, 4 to 6 weeks later, to avoid any leak-related complication. If we find a big bulky stomach, posterior mediastinum not available, we do a gastric tube and take it retrosternal. This is Professor Rao's technique of fundal tube esophagoplasty. The distal most part of the esophagus may get avascular, but it could be trimmed. The main complications of gastric tube are late complications: leak, stricture, GER, and Barrett's esophagus, because the acid secretion of the stomach can lead to major complications. So leak and stricture are very common, though early complications are rare. As I said that we make a neck fistula, but then it could be very difficult to handle because the acid can cause severe excoriation. So you need to manage it like a stomach care and then do an early repair, early anastomosis back. The post-operative X-ray looks very good, normal caliber, like a normal esophagus, and they do swallow well. However, as I said, that stricture is a very common problem. Next thing I'll discuss is colonic interposition. Well, it is a time-tested procedure and mainly used to be done in adults. However, still some pediatric surgeons are doing colonic interposition in children. Needless to say that it requires bowel preparation. You should rule out any colonic abnormality. Right colon can be used, left colon can be used. There is certain zonal preference, as right colon more used in US and left colon more used in Europe. Right colon generally taken retrosternal route, whereas left colon earlier in waterstone operation used to be taken transthoracic. However, nowadays the left colon even can be taken transhiatally, as described by Professor Hamza in a large number of cases with successful left colon transhiatal. So it's the same principles. It can be taken retrosternal, it can be taken posterior mediastinal transhiatal. Will rule out any colonic abnormality or disease. The left colon is based on the ascending branch of the left colic artery. It can be taken isoperistaltic, or a segment of transverse colon can be taken if one requires small segment, or even right colon and ileocolic area could be used based on the marginal artery. So it is very important to study the marginal artery very carefully before starting any mobilization of the colon, as if one fails to maintain the circulation through the marginal artery, graft necrosis is a major issue, especially not only artery, even the venous inking can lead to colonic graft necrosis. I just put up this slide because this appears to be very useful. One can take a long segment of ileum and a short segment of cecum based on this particular anatomy, which has been published from below. And I tell you the usefulness of this procedure is when your stomach is not available for some reason or other, and you have to do a very high neck anastomosis in a caustic stricture. As, for example, this 11-year-old boy who had a caustic stricture and a failed gastric tube, retrosternal, and a very small volume of stomach was left. So what we recourse to a large ileal segment and ileocolic replacement of that esophagus. So took it retrosternally, anastomosed the lower end of the colon to the rest of the stomach, and ileum taken up in the neck. As you can see, it can go up quite high. So the major complications following colonic replacement, as I said, is graft necrosis, early complications. So one has to be very careful. If you are taking based on any vessel, clamp the other vessels, see the good pulsation of the marginal artery, and then only start mobilizing and dividing the vessels before you take them up for anastomosis. Again, anastomotic leak and stricture are two common complications following colonic replacement. And in the long term, redundancy has been found to be a major issue with most of the colonic by peristalsis, but it empties by gravity. So over a period of time, there is a tendency to become redundant, and at times it may require revision of the redundant colon. So this is a summary of all the procedures which I have just now spoken about. Starting with colon, that length is not a problem. Reflux it is quite resistant. However, precarious blood supply, graft necrosis, and redundancy, and multiple anesthesias to handle. But one thing I can tell you, that a staged gastric tube, the major advantage is one can do without ICU and ventilation. Jejunum appears very appropriate for esophagus. However, jejunum has a huge issue with the precarious blood supply. So to get a European centers of good result with jejunum replacement, however, it requires special training and special diligence to perform such an operation. Free jejunal graft requires microvascular anastomosis, only trained people can do. So for stomach, the whole stomach, as I said, length is good, blood supply good. Single anastomosis and no thoracotomy are two major procedure, major advantages. However, the disadvantage is bulk of the stomach in the thorax, which can cause cardiac and respiratory embarrassment in the early perioperative period. And one should be very careful. Even after doing esophagostomy, one could try and preserve the native esophagus and try and do an esophageal anastomosis. So Dr. Kimura and Fokker, Kimura is extrathoracic elongation technique, where the upper ends of the esophagus can be stretched over intrathoracically. The advantage of these two elongation techniques would be that if one can restore the esophagus following the abdomen, and anatomy and function of other organs will not be there. And the big advantage is that you may not need a big intensive care unit setup or post-op ventilation. So sounds very attractive in ideology. However, in our institution, my colleague and myself, we have tried few cases. So this is just to show that the cervical esophageostomy can be elongated can be mobilized and elongated serially, as you can see from here to here to here to here to here. And even if you see the nipple line, you can go below the nystagmus. There is high incidence of esophageal stricture requiring multiple dilatations. And some of our patients, while in the process of elongating, we have lost the upper end of the esophagus due to interischemic necrosis, or as in this case, due to local perforation and large abscess formation, and the whole upper esophagus was lost. So the disadvantages of this procedure is multiple operations with multiple scars. There is unpredictable length gain, continuous stretching of the esophagus leading to vascular compromise and resulting loss of the esophagus. Anastomotic stricture is an invariable problem which may require again surgery, repeated dilatation, and all of them develop reflux because of the stretching. So anti-reflux procedure becomes. We haven't had a very robust experience. The only 30s in numbers of esophageal replacement we have done. But what varieties we have done, gastric pull-up appears to be the commonest thing, and transhiatal is the most common one, followed by retrosternal gastric pull-up. We did 5 gastric tube, 1 ileopolic replacement, and we have attempted so far 8 elongation techniques. However, not successful in all of them. 3 of them required replacement later on. The problem now we realize that with a good perioperative management, especially hemodynamic management, mortality following gastric pull-up, and even their long-term results show excellent, 95% with patient satisfaction. And I prepare myself, how I counsel my patients. Well, this is what I do. I tell myself and my patients that a gastric pull-up, there are perioperative problems, major problems. But once you overcome that, there are few late problems. So if they survive, they remain very well for long term, which has now been well documented. Whereas the other procedures like tubes, elongations, you can get away without much initial perioperative problems. So they're quite safe. You don't require major ventilation. You don't require major ICU setup. However, you should be prepared to handle many other post-operative problems like stricture requiring repeated dilatation, lots of operative procedures, recurrent hospital visits. So when I counsel my parents' family with that and give them the choice, some of them turn up and say, "Doctor, we want what," and I have been able to explain, this would be my first choice. In a child where I do not have big ICU or maybe operating in a little remote hospital where all big setups are not available, a staged retrosternal gastric tube appears to be a very safe procedure because no ventilation, no ICU is required. Or at times, if you have a big bulky stomach at the time of surgery and you think going on retrosternally or posterior-mediastinal is a big issue, make a tube because that works as well. When do we need to use colon? Well, it appears to be a useful alternative, especially there could be situations where stomach is not available or failed previous procedure where somebody attempted a gastric pull-up and or a tube which is necrosed, as we faced in one patient. Colon could be a very useful alternative, especially in corrosive stricture. You could take it very high up in the neck. And anastomosis is quite robust. The different procedures, colon still predominant, maybe earlier, but it would be replaced by gastric transposition. This is like slightly old data. Now, world literature has crossed 200 plus gastric transposition, and then some centers are still persisting with gastric tube. Coming on to 3 main parameters to compare them: death, leak, and stricture. If you see death, no major difference. So no major perioperative mortality. However, we found that our gastric transposition had higher mortality as compared to the other technique. The high incidence of leaks and strictures whereas in a gastric transposition is in the 20s. And let me tell you that leak in the neck following a neck anastomosis is not a very devastating complication, as majority of the leak, whether it is gastric pull-up or esophageal or a colonic, majority of the neck leak, they heal spontaneously over a period of time and did not require any intervention. So just a cervical leak should not make anybody feel extremely unpleasant as it heals over a period of time. The jejunostomy feeding tube for me is a life-saving during the whole perioperative period. And I have been able to manage them long term, even 3 months, 6 months, post-operative, when they are not feeding well, through simple jejunostomy tube. I put them a long Whitzel panel and bring out to the same gastrostomy site, 8 or 10 French infant feeding tube. And I can assure you that if it slips out after 3 weeks for following surgery or it gets stiffened, you can always replace it very easily. Coming on to suggested reading and literature, our association journal, Journal of Indian Association of Pediatric Surgeons, this particular volume has been completely devoted to esophageal diseases in children, especially esophageal replacement, with original as well as review articles. Please refer to those. For postgraduates, published by me, and there's a chapter available. So please refer to your learning. And I must acknowledge all my esteemed colleagues who have been doing. With this note, I would bring an end to this particular talk. Thank you, Ravi. Right, Ravi. Okay. I got your questions. Now, Jayan, pediatric surgery and urology in BLK Delhi. He is asking, India, sir, which is your preferred conduit and route in cases of corrosive strictures? How will you perform esophagectomy, transhiatal, transthoracic? Well, Prashant, the choice is again, if you are attempting a transhiatal esophagectomy, is a blind transhiatal with history of earlier perforation, and I have done gastric tube, retrosternal, and one child, as I have shown, colon. So you have all the options available. You could choose anything. As regards the removal of the esophagus, it depends on how badly scarred the mediastinum is. Ideally, it should be removed to avoid any future risk of malignancy. But if you are in a very difficult situation, you could leave it for time being, do a substernal or a retrosternal, stomach, colon, tube, anything, and review the situation later on. Praveen, Januar, what I know, Praveen, you are in Udaipur. What are the disadvantages if we do pyloromyotomy, oblique casting along with pull-up? Absolutely no disadvantage, Praveen. This is what is recommended in the textbooks. The only issue is that you have extra suture line, so you could have a leak. Otherwise, there is absolutely no disadvantage. The point which I made is that over a period of time, the peristalsis recovers. So if you have a jejunal feeding tube, maybe you may get away with without doing it. We do not have a randomized controlled trial to prove yes or no in favor or against it. But if it is your practice, please continue doing it. Roshan Chanchalani, protocol for starting pre-op beta blockers. Yes, that's a new concept. I mean, I know a few of my colleagues have started doing it. We do it 24 to 48 hours pre-op. And our dose is metoprolol 1 to 2 milligram per kilogram body weight through gastrostomy or jejunostomy, whatever the child has. Perioperative, bring the resting heart rate to 10% of normal. Of course, do a prior ECG and echocardiography to rule out any cardiac anomaly. And maintain the intra and perioperative heart rate within reasonable limit. Don't let the heart rate go to 800, 180, 200, 220, and then try to reduce. By then, you might already develop a cardiac compromise. So if it crosses your limit of 160, 180, and you have corrected other reasons of tachycardia, what it means, fever, pain, hypovolemia, all other reasons for tachycardia should be taken care of. Then only you talk of beta blocker. And we have used it IV also if required and found it quite useful in the perioperative management. Praveen again, how long beta blocker should be continued post-operatively? 7 days is our protocol, but sometime our ICU people, they stop it on day 2, day 3. Sometimes they just monitor it with the heart rate. If they think they start reducing it and watch the heart rate. If the heart rate goes rising again, then again start it. So you could titrate it with heart rate monitoring. But generally 3 to 7 days, you should be able to completely avoid it. Ashish Chabda, about nutrition. What diet you are waiting for the esophageal replacement for a weight gain? Excellent question. I mean, to be very honest and frank, we just send these patients to their family and ask them to feed whatever they normally feed a child. 3-6 months, they all feed milk, and then they increase the concentration of that. They make it more tube well. Always flush the tube after and before feeding so that you don't get frequent tube block. If you have a nutritionist, it would be a great help because pre-digested formula through jejunostomy is very well tolerated. So there are like FTs 90, FT 100, 200. There are different formulas available. So if you have a person who can, a nutritionist who can guide you, excellent. Aditya Bhusham, sir. Sir, do you do single layer or double layer anastomosis in gastric pull-up surgery? Well, I do double layer, but I have read in book that you could do single layer. Arvind Radhakrishnan, do you do the FJ along with the gastric pull-up routinely, sir? Yes, I do routinely. Absolutely. All gastric pull-up, I would do an FJ. And I have got good results. I have no reason to change it. But the point is FJ are known to have complications. So one need to know a good way of doing it so that you don't see those complications of leak especially. And as I said, tube dislodgement after 2 to 3 weeks when the track is formed is not a major problem. It can be replaced. Prashant again. Will you keep colon prepared, which might be required in cases if you find compromised any segment as we have discussed so far? Raghu, Prakash, how to manage recurrent vomiting happening even after 1 year of gastric pull-up? Raghu, very, very pertinent question. Gastric pull-up is a procedure. You lose all the sphincters. The GA junction gone, the esophageal sphincters gone. So it is just a straight tube. So your child is very prone to reflux, everything. And it is very common in the early perioperative period. And all surgeons have faced this. Who has the maximum experience? The people who have done it and followed it for a very long period. So I quote Professor Louis speech from Great Ormond Street, London, and Professor Arnold Coran, the two pioneers who are still continuing with this procedure. And when I asked them and read their publication, they said that over a period of time, it settles down. How long? 1 year, 2 years, 3 years? I do not know. But do general anti-GER measures like propped up position, keep the child upright most of the time, give small frequent feed, give Anzol Junior, take all anti-GER measures and hope that over a period of time it gets care on its own. Basant Kumar, Is pyloroplasty, pyloramyotomy reduce incidence of GER? No, they would increase the incidence of GER because you may have even alkaline reflux. Site of cervical anastomosis, is it on posterior wall of stomach or midline or anterior wall of stomach? Okay, if you are doing a gastric pull-up, it is right at the fundus, neither posterior wall nor anterior wall, right on the midline on the fundus. If you are talking about the neck anastomosis, it is right in the fundus of the stomach. I hope that is what you wanted to know. Aditya, do we decide for colonic transposition, not gastric pull-up? Is there any role of preoperative imaging to assess gastric size? Well, Aditya, I think what your question is that if you have a gastric abnormality or a colonic abnormality or a big bulky stomach, should you be preoperatively prepared in your mind? I think yes, there is a merit in that. In most of our pure esophageal atresia, as you know, we always do a contrast study through the gastrostomy. The reason we check the lower end of the esophagus, whether sometimes you might have a worry, is there a missed lower tracheoesophageal fistula? Majority of it in all these children esophageal atresia and diseases. That's number one. And do a contrast study through the gastrostomy, so you know the volume of the stomach and lower esophageal rotation, ARM, polyposis, or any other condition. You would not use it. So pre-op assessment has definitely got useful role. Dr. Ellis, barium enema study mandatory before colonic transposition. Well, again, a debatable issue, but each patient, if you have a patient with anorectal malformation or some colonic, is the colonic vascular arcade. So I'm not sure whether barium enema is mandatory or not. We haven't done that. And vascular arcades are essentially assessed intraoperatively. One need to very carefully study the marginal artery of Drummond and the principal vessels based on which you are planning to do the pull-up, so that you don't interfere with colonic, not only arterial supply, but also the venous drainage. In your review of literature, you showed commonest procedure performed is colonic replacement. This majority is, if you read Professor Hamza's colonic replacement in Egypt, they get a lot of gastric esophageal stricture, and he has done colon is predominant because some people, especially in Egypt, have used it very frequently and liberally for caustic strictures. And I guess that is the reason. But all the latest literature is GP better procedure compared to other? Well, again, as I said, that you have to assess each procedure, its merits and demerits. You just can't point one procedure better than other. As I said, that if I have to do a gastric pull-up in a remote center where I do not have proper monitoring facility and ICU ventilation, the patient could die. And that's not a good outcome. But if I do it in a center where all facilities are there, where I have no mortality, these patients, once they recover, they will have a normal course of life. So that way, it is a very safe, a good procedure. In other words, if I do a gastric tube, retrosternal, do a fistula first, I don't need a big ICU, big ventilation. I can do it in a remote center because I would do a late anastomosis, so even the chance of leak is less. So again, as I said, that you have to apply your own judgment, your situation, your training, and your experience. So one thing is extremely certainly sure, that for beginners, don't venture into practicing different procedures. First, learn it well. Learn it from a center where major number of cases are done. Learn the tricks, and then only venture into it. Then you will produce good results. So your training, your institution of practice, has a major role to play. Ravin Radhakrishnan, how to prevent the possible kinks at the neo-esophago-gastric junction in a gastric tube procedure? Well, upper end, especially, I can tell you, the clavicle and the sternoclavicular junction is an issue, especially if you are doing retrosternal, whether it's stomach or colon tube. So a good thing would be nibble off the head of the clavicle and part of the manubrium sterni. That will give you an extra room to accommodate your conduit, and that will give you a good anastomosis, as well as there will be less chance of kinking the neck. How common is this complication, and any recommended angle measurements to avoid this? Well, only one thing I can tell you, that a tube which is either too tight or too loose is prone to all these complications. Colon, for example, I mean, if you keep it redundant, then it is going to kink. So you have to trim it to make it exactly the length from the esophagus to the stomach where you are going to join the colon. So you need a measurement. Whereas the stomach, the whole stomach, is quite bulky and rigid, and they don't become redundant and they don't kink. So I think kinking and redundancy are colonic problem and not issue stomach. Of course, again, you can't do a very tight anastomosis. That itself is stricture. So good balance. That's the answer to that. Ankur Mandalia, sir, any role of prokinetics in follow-up after GPU to improve gastric empties? Oh, certainly, certainly. I mean, you try metoclopramide, you try domperidone. Cisapride is not given these days, and some people have even used erythromycin. Sure, sure. Why not? It will have. Well, I have been told last question. Rohit Kapoor, sir, do arrhythmia occur in gastric pull-up through retrosternal route or just posterior mediastinal route? Well, Rohit, very, very intelligent question. I was trying to avoid these, but you caught me. In our patients, majority of the problems we faced were posterior mediastinal with cardiac arrhythmias. But I know that people have faced some issues, whether arrhythmia or compression, even in the retrosternal route. So to answer you indirectly, yes, posterior mediastinal route appears to be the suspect for cardiac. So that's your answer, Rohit. I hope I have been able to give you an answer. Any more questions? It's pleasure, Ravi, to be on this platform and to able to reach people at home. And thanks to technology, thanks to your intervention, each other, we should be able to transfer, convey our thoughts, and learn from each other and interact with each other. And it has been an extreme pleasure for me to share this platform. And I also learned a lot from this presentation. Thank you so much. And I wish you all a safe time, safe stay, and enjoy the festival with your friends, family, and stay safe. Thank you.